Hello, everyone. Welcome to Mental Health in 22Q. We are very excited to be offering this webinar. My name is Lindsay Garcia, and I'm the Executive Director of the 22Q Family Foundation. If you're just joining us, we're going to give everyone a few minutes to come in. I see the participants rolling in right now. This has been our biggest turnout as far as webinars go with the 22Q Family Foundation. So we have 110 people registered. So we're hoping for a great conversation and a great amount of resources and support for all of you in the 22Q community. While you're coming in, I just want to briefly go over the agenda. So I'm going to be introducing three different speakers that will be talking to you in a moment. And then we're going to kind of dive into early signs and symptoms and red flags of different mental health issues, so whether it's anxiety or depression. And then we'll talk about medications and different resources that can help you and your child. So, and then following up with some Q&A at the end. I do just want to say that if you are joining us, please remember to keep your questions relatively general, just because we do have a big turnout. And if you do have any further questions that are a little bit more in detail, feel free to email me at the end of this, and I can relay those back to the medical professionals that are with us today. So without further ado, we're going to get to our introductions. So again, my name is Lindsay Garcia. I run the 22Q Family Foundation. I also am a parent of a child with 22Q. He's 7. So I'm very interested in this topic because I'm starting to notice lots of anxiety and different things that come along with that. Our first person that is going to be speaking in just a few moments is Joy McClellan, and she is a mom and a parent of a child with 22Q. She's graciously sharing her daughter's mental health journey, and she's very open and honest about it. And so we're excited to be able to have her start off our talk. Following Joy will be Dr. Klima Bolden, and she is a licensed clinical psychologist, as well as a health sciences assistant clinical professor and the assistant director of clinical training at the UC Davis Mind Institute. And we're very honored and appreciative to have her today with her expertise. And following her will be Dr. Kathy Inkuseri, who is the Associate Professor of Clinical Pediatrics, the Medical Director of the 22Q Healthy Minds Clinic, and a Fellowship Director, Developmental Behavioral Pediatrics, also at the UC Davis Mind Institute. So very honored, very excited to have these three ladies joining us today. We're going to go ahead and get started. I'm going to go ahead and stop sharing my screen. And I'm going to introduce Joy, who's currently on my left, but might be a different quadrant of your screen. Thank you so much for joining us, Joy.
Thank you. Thank you so much for having me. I'm really excited to share our story. Maren was born June 18th, 2004. And the last words that the neonatologist said to us when he discharged her from the hospital were, "She's fine. She's just going to be more difficult than most." We didn't know at that time that she had 22Q, a cleft palate, and a PDA. As an infant, she cried a lot, she didn't sleep much, and she hated the car. When she was 15 months old, we finally received a 22Q diagnosis after we advocated and pushed and saw a lot of doctors. When she was in preschool and she became verbal, she started with perseveration. And that was the first thing that we noticed that showed us that there might be some anxiety. She also had some social anxiety. She would get so excited before we went to a birthday party and tell me all the people she was going to talk to and all the people she was going to play with. And then when we got to the birthday party, she just clung to my leg the entire time and didn't talk to anyone. When she was in first grade, she was in a new school, and I noticed that she had scratches on her arms. And I asked her about it, and she said, "Well, I've been scratching my arms with my fingernails." And I knew that self-harm was a big indicator or warning of potential mental health issues. So we went ahead and got in with a therapist at that point and started cognitive behavioral therapy. In second grade, she was in another new school. It was a more challenging environment with a lot more homework. The social struggles became more obvious. While she was well behaved and well liked by her teachers at school, when she got in the car every day when school was over, she would start scream the whole way home. and we would struggle throughout the night to get homework done and all the things that she needed to do. At that point, we received a diagnosis of ADHD and also autism. We tried ADHD meds for focus in school because inattention was her biggest issue. And there were side effects from all the meds that we tried. She stopped eating. She developed OCD like tendencies, and she was very agitated. So at that point, we decided to stop the meds after trying several different medications. In third grade, her social struggles continued. She had struggles with her schoolwork, more homework struggles, and we realized that the environment that she was in was not going to work for her long term. Before the school year was out in third grade, we found out that we were moving to Little Rock, Arkansas, and we had 6 weeks of the school year left by the time we moved to Little Rock, and decided to try homeschooling for 6 weeks because we knew the school situation she was in was not working. I was so tired of sitting in IEP meetings and advocating for her needs when I felt that people really didn't understand her. And so we homeschooled for those 6 weeks. We noticed a huge change in her anxiety and her mental health, and we decided to keep the homeschooling up. She did well until age 11, which is when puberty started. Then the anxiety and the mental health issues really ramped up. There was a lot of agitation and irritation, threats of violence and self-harming and running away. We started therapy again and eventually started meds. We weren't finding a med that worked, and our psychiatrist was not a good fit. We ended up in the ER one day when she was 11 because she was threatening to run away and to harm herself and others. So we took her to our local children's hospital and found out that they do not have psychiatric services. They basically discharged us because it was after 5 o'clock in the afternoon, and she didn't act out while she was actually in the emergency room. So they said there was nothing that they could do for us. Fortunately, we were established with a 22Q clinic and at Nationwide Hospital in Columbus, Ohio. And she had been established with a team there for several years, and the psychiatrist and the psychologist. So I called them and they said if I could safely get her there, they felt like she probably needed to be hospitalized. So the next morning I got up and drove 11 hours to Nationwide. We came in through the ER and were admitted for our first 5-day inpatient stay in their psychiatric unit. She was diagnosed with autism again for the second time, and she started risperidone. We returned to Little Rock and found a new therapist and a new psychiatric nurse practitioner. Marin gained weight on risperidone, so we had to start a new medication for that. As she had new struggles, we'd just try new meds. After working with Marin for a while, her psychiatric nurse practitioner diagnosed her with bipolar 2. When I became educated about bipolar disorder, the diagnosis really fit Marin, and it seemed like we finally had an answer and a way to help her. Kept trying meds through the entire time we were in therapy, but she still struggled. At a certain point, we actually discussed removing Marin from our home because things were so bad. Our home life was disrupted, and she has a younger brother that we had to consider. And when you're that deep in the trenches, a lot of times it doesn't feel like there's a way out. At age 13, she started asking to go back to school. We knew that a traditional school setting would cause her to struggle and probably be detrimental to her mental health. So we decided on a private school for students with learning disabilities. And the routine and structure really helped, as does the small class size. We've had 2 more hospitalizations, both locally, one which was disastrous, and I ended up removing her after 3 days. Marin is now almost 17, which she will not let us forget. She is popular at school. She has a lot of friends. though she prefers FaceTime and texting to social events and hanging out in person. She rides horses weekly. She participates in competitions. And she loves art and reading. She meditates and does yoga or exercise daily. She's learned to be a partner in her mental health, which is extremely important. She's also learned to advocate for herself and to tell us what she needs. We've had some dark days, and we know that there are likely more dark days in the future. The combination of meds she's on right now is working, but will certainly need to be tweaked as she gets older. And like many of you, psychosis in the future is always on my radar. But through it all, we remember she's fine. She's just going to be more difficult than most.
Well, you had me tearing up. That was just so amazing. I think sharing your honest truth about Marion's journey is something that so many of our families are dealing with, hence why we have such a huge turnout on this topic. But I really felt like some of the important takeaways from what you said, just having, getting your kids to the point of being their own advocates and being their own partner. I think so many of us that have younger kids, we're doing it for them right now. If you have younger kids, and as you get to that transition to adulthood, it's really important, not just for mental health, but it's just across the board to be their own advocates, because we won't always be there for them. And, it's going to make them the most successful. So I do appreciate you being so open and honest. So if you have questions for Joy, feel free to put them in the comment box. And also at the end of our discussion, we're going to allow for about 15 or 20 minutes of Q&A. So you can direct those in. Thank you so much, Joy.
Thank you.
So next up is Dr. Kalima Bolden, and she's going to be sharing her screen and sharing with us red flags, early signs of mental health that could come up with your child. So welcome, Kalima.
Thank you so much. There is a question, so I wanted to give Joy a chance to answer.
Yes. Are you referring to the one about the private special needs school? Yes. How did you find that school? How did you find the private special education school for Marion?
We actually just got lucky in the fact that there's one in Little Rock that has an amazing reputation, and there are actually people that move from other states to put their children in this school. So for us, we lucked up on it.
Thank you for sharing. And yes, this entire presentation is being recorded, so it will be up on our YouTube channel early next week. All right, Dr. Kalima Bolden, we're excited for your presentation.
Thanks so much. All right. Thank you so much for having me, and please feel free to drop questions in the chat at any time, and I will do my best to make sure I can answer them. And as Lindsay said, we'll have some time at the end as well to answer questions. So in 22Q specifically, childhood psychiatric conditions are often reported. There's often comorbidities, meaning there's usually more than one diagnosis at play at a time. And considerations for those diagnoses include different medical conditions that might complicate the presentation, the need for hospitalization, and developmental delays. So I'm going to talk briefly about the most common psychiatric disorders that are reported in 22Q, and some of those early warning signs with a bit of information on what psychotherapeutic treatment looks like. Dr. Angastiri will come next and to discuss more of the medical and pharmacological aspects. So childhood psychiatric concerns in 22Q, the most common reported disorders are those in the attention deficit spectrum. So about 30 to 50% of 22Q kiddos tend to report difficulty with attention and concentration following multi-step instructions and impulsivity and hyperactivity. Additionally, we see a constellation of different anxiety disorders, often specific phobias, but you'll also notice some separation anxiety disorders, OCD, and general anxiety disorder. There sometimes can be some social anxiety that's usually complicated with the fear of not knowing what to do. So less that they're fearful of interacting with others because they think, they'll be made fun of or harmed, and it's more, I just don't know what to do in those situations. And then different mood disorders, primarily depression, but also some presentation of bipolar disorder that's a bit less common. It is often thought to be there, but it's usually that the idea of the mania is more about that impulsivity, difficulty regulating your emotions, and less true mania. And I'll talk about that in a little bit. And so there are some under-identified psychiatric disorders, primarily because kiddos with 22q kind of, because the medical aspects are often the first thing a doctor is going to think about, some of the psychiatric concerns don't get as much attention as they should, especially when they're kind of in those early stages. They're usually thought to be part of developmental delays or, difficulty socializing. And it's not until there's a significant problem that healthcare professionals will start to understand that there's a psychiatric condition at play here. And so early signs are really important, and I'll go through the different early signs you might see, so that way you can advocate for your kiddos. I'm just gonna make sure I don't miss a question in the chat. Okay, great. Okay, so let's think about some of these common early warning signs. So each of these illnesses have their onset somewhere in late childhood to early adolescence. So anxiety, depression, and psychosis. I'm going to talk about what each of those might look like and discuss some of the ways in which you might see a slight difference in individuals with 22q. So what defines an illness? Everyone experiences different things on a continuum, from those things that are what we call within the normal realm of experience versus when it becomes a problem and is linked under a psychiatric diagnosis. So having a few sad days or being sad about something is 100% common. Everyone gets sad. I get sad. There might just be days where you're in a funk. You're not particularly sad about something. You're just not having the best of days. And then you usually kind of get out of it and are able to go on and be fine. And then there's times when folks are sad all day for weeks on end, sometimes months on end, and that's where we get into clinical depression. Similarly, drinking with friends socially versus having to drink throughout the day, that's the difference between drinking alcohol and then having an alcohol use disorder. Or getting a little bit nervous before a test is common. I still get nervous before I speak in front of people, even though I do this pretty much weekly. And that's different than having a panic attack before I have to talk, or being so afraid of public speaking that I actually can't do my job. So all of these different things exist on a continuum. And what we want to do is try to catch it when the continuum is getting right to a critical point where I don't know that this is something that you should be experiencing every day. Yes, please ask any question you have. So when that comes up, just let me know and I'm happy to stop and answer a question. So when we say things are unhealthy or abnormal, we're talking about how often they happen. So how many times is it going on? How many times are you experiencing this? For certain things, if it's like, oh, it just happens once in a while, it's pretty intense, but it happens. We wouldn't necessarily consider that an experience. We would say, or I'm sorry, a disorder. We'd say, okay, that's something you might want to, just start to monitor and work on so that it doesn't become more persistent. And then pervasive, how many different situations does it happen in? So a kiddo that gets fearful at night, because they think monsters might jump out the closet, is perfectly normal for someone who's 5 or 6 or 7, all the way even up to, 10 or 11. But if it becomes, no, I'm really worried that people are watching me and might harm me, throughout the day in different situations, then now it's something that isn't just about, I'm a little bit scared of the dark when I'm about to go to sleep. It's, I'm scared because I'm worried about harm. It needs to be excessive, significantly distressing, and have a pretty big impact on their life. So whenever we think about disorders, we don't want to penalize or pathologize individuals for just being upset or just having, some times in which they get distressed. So we want to make sure that it's meeting kind of these 4 criteria, that it's really upsetting, it's really impactful, and it's happening at a certain level, a certain amount of times, and in certain different situations. Okay, so we will talk about best ways to seek care. So some early signs of an anxiety disorder. So about 25% of adolescents and 28% of adults will experience an anxiety disorder in their lifetime. So anxiety is characterized by excessive worry. Sometimes the worry can impact your ability to sleep. A lot of times folks will report that difficulty shutting their brain down at the end of the night. They just can't stop with all of the different can even lead to some physical problems. Anxiety is so significantly linked to stress being held in your body that folks might develop TMJ even from clenching their jaw throughout the day, or you'll feel like really excessive muscle fatigue because of how tense you're holding your body throughout the day. Additionally, you might have some somatic symptoms such as having an upset tummy, chronic headaches, and things of that nature. Fears are out of proportion to the situation. So all of us probably have something that we're afraid of. I am terrified of bugs, snakes, and vermin. I've accepted this in my life. I don't deal with them. I have someone who does. But those are things that cause me significant fear because I'm worried about something happening. But if I had to get on a plane or if I had to do something for my kids, I wouldn't let a bug or a snake or something that stop me. So the fear has to be what we call disproportionate to the situation. So worried about something that you're paralyzed and can't do anything is usually what we're talking about. Or, something being worried that something might happen to your parents, and separation anxiety is really common, but the worry is really disproportionate. It's not because something has happened to them. It's not because something's happened to someone else's parents or anything like that that kind of triggers that fear. It's just this general significant fear that once my parents are out of my sight, some like heinous thing is going to happen to them. And so I must prevent them from leaving my sight. It can be characterized by panic attacks. So panic attacks often mimic heart attacks. You have racing heart, sometimes dizziness, hyperventilation, and things like that. And the onset is rapid, meaning that you get to the peak of a panic attack within a couple of minutes. Fear of mistakes is a significant anxiety symptom, and fears related to people, as we talked about, with something happening to parents or being super fearful of abandonment. So anxiety in children can look a little bit different. Sometimes it's just general clinginess, noticing that no matter where you're trying to go, and even in your own home, kiddo doesn't want to leave you alone or doesn't want you out of their sight. It's pretty common in separation anxiety. Tantrums and panic attacks are also common. Refusing to go to school, some really extreme worries about sleeping away from home, and difficulty falling asleep without parents. This might look less like difficulty falling asleep without parents and can just look like your kiddo checking on you throughout the night. So frequently coming into your room and saying, Mom, can I have a glass of water? Mom, can I have this? Mom, can I have that? And you're like, why aren't you, it's 2 a.m. Why aren't you asleep yet? But it's that they can't go to sleep and they want to keep coming in to see that you're okay, and they come up with excuses to be in your room. Social anxiety can look like shyness. So we don't want to penalize any introverts or shy folks when it comes to social anxiety, but it could be this just general kind of caving in almost of kiddo when they're around their peers. So really extreme shyness. And when you ask them what it is, it's they're so worried about making a mistake or being embarrassed in front of others, or that they'll say something and other people won't like them, that they're paralyzed with that fear. They worry about doing anything in front of their peers, so not just socializing, speaking in front of their class, having to even perform in sports or other activities in front of others, and often accompanied with some general low self-esteem. And so, as I was saying before, this is slightly different than some of the social cognition impairments that we see in autism or in individuals with 22q. That difficulty knowing what to do in a social situation, how to read those social cues, can lead to a tendency to not engage because they're just not sure what to do. And that's a bit different than social anxiety, which is this general fear of the negative evaluation they'll receive. OCD is pretty common in kiddos and can look like repetitive thoughts or repetitive behaviors. So sometimes when you talk to them about why they must line something up a certain way, they'll say, oh, just because I like that. That's common and fairly okay. If it's I have to do this, that's when we start to get into the realm of this being a compulsion. And then in general, there might be just a significant GAD type worry. So worrying about tons of different things. What about this? What about this? You know, almost to the point where it's, why are you even thinking about that? So if you feel like you're asking yourself or your kiddo that question, it could be that they're having just so many different pervasive worries that they might be getting into the generalized anxiety disorder category. Seeking lots of reassurance, and then kind of overreacting when even something a little bit bad happens. As we said, there can be some somatization, so tummy aches and headaches are frequent complaints. You might see nail biting and nail picking, scratching or self-injurious behaviors. It's not necessarily with the idea to harm themselves, it is through the worry. So there's a bit of a difference between intentional self-harm and kind of just picking at different parts of your body because you're worried. So just, you know, kind of like constantly biting your nails to the point where they might even bleed. They're not trying to harm themselves. They're so worried that they can't stop. So depression is a wide range of different things, and it isn't necessarily categorized simply by sad affect. So most people think of depression, they think of someone who's extremely sad, who can't get out of bed, and who cries all the time. And that is a presentation of depression. In kiddos, it actually can look really different. Instead of continuous sadness, it can be kind of this general lower mood, kind of dampened mood that's often marked by irritability. Just this general way of being particularly tantrumy or temper triggered. So, you know, little things that wouldn't set them off normally starting to really upset them, seemingly for no reason. In 11% of children and 70% of adults, we see lifetime depression disorders. And so some of these early warning signs are kind of this general sadness, as I said, but it's often marked a little bit by hopelessness. Things aren't going to get better. Or I'm always going to be X. I'm never going to be good enough. You know, that general, like, this is just going to be bad for a while. Not being as interested in things that they normally like to do. So my 10-year-old loves Fortnite, and the minute he stops, I mean, I'm going to do a happy dance, but if it feels excessive and it's not replaced by another pleasurable activity, I'm going to wonder if something is a little off. You might see some disturbances in their sleep, appetite, thinking, and energy. So sleeping a great deal to the point where you're, you know, kind of worried about them, or not sleeping at all. Changes in their appetite. This is hard with kiddos because their appetites fluctuate so much. But if you see consistently for, you know, a few days on end, either a general dampening of their appetite where they just don't seem really interested in eating, or they seem excessively eating to the point where you're wondering what's going on. And this is a little different from, you know, when my 10-year-old is super active and he's running around the house and stuff, he's constantly eating because he's burning off so many calories at any given moment, versus when he's not doing anything. He's just kind of like, you laying around the house watching TV or something like that, he's not going to be as hungry because he's not burning off calories. But if he was constantly eating during those times for a few days on end, again, I would start to worry. Difficulty with concentration, and you'll see a dampening of their energy in general. You might see them not as interested to talk to their friends as they normally would be, and not just peers in general, but people they've actually identified as their friends, or be less interested, like I said, not just in things that they, activities they enjoy, but even if they enjoy schoolwork or reading, you'll see them not do those things as much. And you'll often, not often, but you may notice that they have some general ideas about suicide or self-harm behaviors. Those can just look like, I wonder what it would be like if I'm not here. That what we call passive suicidal ideation, a general wondering of, should I really be here? Is it worth it for me and for other people to have me on this earth? And then when it comes to psychosis, about 20% of individuals in the general population have psychosis-like experiences, but 3% will have persistent psychosis symptoms that start to impact their lives. Psychosis symptoms also exist on a continuum. So it could be something like suspiciousness, where just this general worry that people might have negative intent or harm towards you, all the way up to what we call full threshold psychosis, which is true paranoia. Thinking that there is a specific person or entity out there that they actively are trying to harm you and you must protect yourself. Sometimes unusual thoughts or fears, so feeling as if you can read other people's minds or they can read yours, that messages from the TV or certain songs are meant specifically for you. So not just like, oh yeah, I saw a commercial about a slip and slide and then I wanted to get a slip and slide. Well, that's good advertising. That's different from, I saw a message about going to Disney World and I believe that Mickey Mouse was telling me I needed to be there for a specific purpose. So that's kind of that difference. Feeling as if you're particularly special and chosen for a particular role, things of that nature. And then some changes in sensory experiences. So for kiddos with 22q, they often have, they're often particularly sensitive to sensory things, sensitive to sound, sensitive to certain fabrics and touch and things like that. It's when you see that shift. So if they've always been sensitive to sound, that's something that's probably part of either their 22q disorder or if they have a separate autism diagnosis. But if it's new, so something that wasn't there, and then around 11 or 12, they're becoming more sensitive to sound or seeing things out of the corner of their eye, et cetera, you might want to say, okay, let's just, keep an eye on that. Hearing sounds or hearing their name being called, seeing like shadows or misseeing a lot of things can also occur. And then they often occur in the context of other vague difficulties. So you will see some of these symptoms we talked about in depression and anxiety with these other symptoms. So a general disinterest in social and school activities, just feeling really overwhelmed by the day. So especially if something changes in their day, they might start to really have difficulty. And again, that's got to be a departure for them. So if they've always needed that kind of structure and expectability for their day, that's different from all of a sudden them needing it. So what can help? When faced with any psychiatric condition, just like a physical illness, you're going to want to talk to a healthcare professional. So you're going to want to talk to your physician or a mental health care practitioner or family or friends to see if they have any resources that might be helpful. Discussing with your child's school guidance counselor, different community organizations such as NAMI, the National Alliance for Mental Illness, and possibly going through your church. Here are some psychotherapeutic strategies for managing anxiety and depression. So we do these in kind of three prongs. We focus on coping with the actual issue, a stressor. So in OCD or other specific phobias, we say, what's the thing you're afraid of? Let's work on that. Or we talk about emotion-focused coping. So being able to manage your distress in those situations, how to learn how to deep breathe, relax your muscles, picture yourself somewhere calming and relaxing, manage your physical energy by using strings and things like that. And then meaning focus, being able to change how we conceptualize different things. So understanding that something seems scary doesn't necessarily mean that it is scary. Psychosis uses similar techniques, but we do more services. So coordinated specialty care is the gold standard model for treating psychosis symptoms. And so what that means is you have a care team. You have an individual therapist who does a lot of those strategies with individuals with psychosis. You also have medication management for individuals who have full threshold psychosis symptoms. If you're in that in between where you're having those kind of perceptual abnormalities or suspicious or unusual thoughts, but not full threshold psychosis, we don't necessarily recommend pharmacotherapy for that, or at least not antipsychotic pharmacotherapy. We also do group work, so group therapy work, and then we have a family advocate, a case manager, and we all try to wrap the families in care so that they're getting all they need and we're boosting those protective factors. And so any questions, I'm also happy to take them at the end, so I'll stop sharing now. That's me and my talk.
Thank you so much, Dr. Bolden. Yes, I do have questions. I think we're going to save them to the end just because of time, but I really appreciate you kind of highlighting the differences between, everyday fears and worries and actual mental health disorders that could come along with our children. So next up, we're going to have Dr. Kathy Angus-Theory, who's going to be talking more about medications and different forms of treatment and resources.
Great. Thanks, Lindsay. Thank you, Kalima. You covered a lot so quickly and it was great. And then Joy, I just want to say thank you so much too. I appreciate your story. And I think you've highlighted a lot of the things that Kalima talked about and I'll talk about too. And so it's really helpful to have your perspective. So again, treatments and recommendations, this is kind of a broad start here. It really varies based on individual needs. And so I'm going to go over kind of the array of possibilities, but just kind of more general ideas to help guide us to think about what we're looking for when we're trying to help our kids here. So of course, we want to maximize behavioral and educational therapies. Those can be extremely helpful. I mean, I think as Joy mentioned, having structure and routine goes a really long way for helping to manage things like anxiety, but also just our kind of everyday living skills and work towards being independent adults. So I don't want to minimize those, but since we've already talked about some of them and I kind of want to get you to some of the data on medications and things like that, I'm going to focus more of my talk that way. In terms of thinking about medical comorbidities or other things that are going on, I think most of us have been checking or will be checking for, differences in our thyroid, calcium, looking for anemia, all of these things. I would have a lower threshold for an individual 22q to be looking for as an explanation for symptoms like low energy, which can look like depression, right? Or low mood or headaches or irritability. Sometimes that's something that might actually be related to a medical condition. Most of the time those things are normal, and then I would go on and continue with the usual psychiatric treatment. But I think sometimes general providers who aren't used to thinking from a 22q frame are less likely to be thinking about maybe investigating medical causes. So remember some of those things. And then some of our kids are on medications. So some of those can cause side effects, like even just antihistamines can cause problems with sleep, either more or less. So just kind of keeping a wide circle of what's going on and what could be contributing or adding to symptoms. And I so appreciate, Joy's comment about having a team together to help support her early on so that, when she needed help for something that needed to happen more quickly, she had that support in place, not just to help advocate for families, because sometimes it's hard when you're telling your story for the other side, the medical side, to hear it or give it the kind of credence it needs, but also because there's another bunch of people who have a baseline for your child. They know what your child looks like when they're, at their usual, and they can really elevate kind of concern when you're like, this is not what your child's usually like. We see that as well, and we can go ahead and move forward with treatment to improve things. All right. this isn't advancing here. What do I need to do? Okay, so in some considerations, it's really important that you're determining your target symptom and that it's impacting function, that like Dr. Bolden said, right? Just because you have ADHD doesn't mean that you automatically need medication for it. I mean, many times you may, and if it's getting in the way and you're trying all of your classroom accommodations, then maybe it's time to go ahead and do that. But I don't think the decision is just a reflexive, if you have X diagnosis, you need Y treatment. It really is individual to the person and their situation. And generally speaking, we don't have any specific medications for children who have 22q. That being said, the medications that we have for ADHD, for anxiety, for depression and mood, for irritability, psychosis, those things can be used effectively for individuals with 22q. There's nothing different about these presentations or about response to treatment. And in general, we think about starting low and going slow because we might have side effects, you know, Marin did. And to know that's going to be part of the course and to be patient with it. So for me, usually because we're not sure how kids are going to metabolize some of the medications, starting low, I mean, even though you may not see something right away, is maybe sometimes a gentler way to go and then move up to the dose that works well. And a lot of times we don't really know what our right dose is until we've kind of overshot it a little bit and the side effects are there. And then we can go back down to the place where we get the best therapeutic effect without the side effects. I already mentioned this, combining modalities. So you're using therapies as well. And every child responds differently. I mean, although siblings may tend to have similar responses because our livers are, metabolize medication more similarly because of genetic reasons. But, you know, sometimes something that worked for your neighbor with the same condition isn't always going to work for you. And like I said, this is expect changes in dose and medication types. We have many options to use. So before I review the data for you, I just want to remind you that we have very few medications that are FDA approved for use in children under the age of 6. We have a bit more for, you know, school-age children and teens, and then certainly a lot more options for adults. There are few randomized placebo-controlled double-blind studies. So that's your best kind of study where, you know, you're comparing an experimental medication to a placebo pill, a sugar pill, and both sides don't know who's on what. But again, these are hard to do and not many have been done in children. And then even fewer studies have been specifically performed in the 22q population. And I'll review for you everything that at least has been reported in clinicaltrials.gov. And so again, thinking about what's the target treatment and how does it work? Because sometimes we don't have that really strong discussion with our provider beforehand. And I think that's really important. What am I looking for? How will I know if this is helping? And if it's not helping, then maybe we shouldn't continue it and we should try something else. But there are many times, you know, we just keep chugging along because the doctor told us to. How impairing is the behavior we talked about again. Risks and benefits of treatment. So something that has high risk to it may not be worth the benefit, you know, of using it if it's a very small likelihood. And so I kind of have this box here of thinking about how effective is a medication, and most of the ones I'll review for you and let you know if they are effective, but are they safe or do we not know? And, you know, we have to be careful in these kind of green boxes. Whereas if it's something, you know, very experimental that we don't even know if it would work or that there's a theory for why it might work, and we know it's not safe, you know, for example, like chelation in autism, where you're taking out heavy metals from the body, that's something that has serious harm, like death and arrhythmias. That's not worth it, and we would discourage it. I think the harder thing is when we don't know, when we don't have the data for it. And, you know, I think in that case, it's really worthwhile talking with your doctor about, well, maybe we try a trial for like a week of a very small dose and see how it goes. And if it's almost like doing your own little study, since we don't have the data for it. But just, you know, using that framework to think about if something's worthwhile to try. Again, what are we targeting here? So are we looking at inattention, hyperactivity, impulsivity, different types of anxiety, mood, or aggression? Because you're going to choose a different agent based on what the target symptom is. So I'm going to review quickly for you ADHD treatment. So certainly you want to start with behavioral interventions. And for the younger kids, that's really about parent training, like that structure and routine. It helps so much. And, you know, kids with ADHD learn a little bit differently. They respond to rewards and consequences differently. So there are some really good evidence-based programs like parent-child interaction therapy. Sorry for the abbreviations there. I should have spelled it out. Incredible Years, Stars and Triple P. Those are all really good programs that could work very well for young children, for training parents to manage behavior in young children. And then for older children, things like cognitive behavioral therapy can work really well too, and helping to give them strategies in addition to kind of just organizational tools and other things. CHAD has some great examples. Understood.org also has some really nice modifications that can be made in the classroom, and those can go a really long way. I also like to include kind of books that are helpful to be guides for families too, and Russell Barkley is kind of a leader in that field. And I know a lot of parents like this book too, Smart But Scattered. It's helpful. So I'm going to move forward to the medications. Stimulants, so things like Ritalin, methylphenidate, Concerta, Adderall, those are really your first line treatments for ADHD, but I know there's a lot of concern for use of stimulants in kids with 22q because, you know, these things can increase heart rate, increase blood pressure, and some of our kids have cardiac heart disease. The other thing is, you know, a lot of our kids have problems with growth, at least initially, and so the stimulants can suppress appetite. And so they can have not really long-term effects on growth, but more short-term ones. And we certainly don't want our kids to be losing weight or things like that. Again, there's a theoretical risk. This hasn't really been, you know, kind of confirmed, but that, you know, people with 22q only have one copy of the COMT gene, which is an enzyme that breaks down dopamine. And so some of the worry there is that if we don't have the 2 copies that we should have, we might not be able to clear this medication as quickly or as efficiently as the general population. Again, we don't know this for sure, but it's just a theory. So what do we know about using things like Ritalin in kids with 22q? So this area is the one that's had the most trials done and registered. And Dr. Gotthelf has done most of them, which is a little bit old now. And this is just looking at short-acting Ritalin, right? Lasts maybe 3 hours or so. Not a lot of children. These aren't large studies, but they're the only ones that have actually been done in kids with 22q. There's a current one going on in Geneva. It hasn't finished yet, looking at long-acting methylphenidate, which is called Concerta, is one brand name. And the consensus has been that, you know, these medications are first line for ADHD. They are FDA approved for children in general for ADHD. And that in 22q, the methylphenidate is effective and usually well tolerated. So we can use these safely with good effects, but we want to watch out for side effects and potential risks. And, you know, if your child does have a cardiac history, usually you want to check in with your cardiologist first before going ahead with that. And again, weighing your risks and benefits with your provider. So other options instead of that, if that is not something that is a good fit, are non-stimulant medications. So there's something called Strattera. The generic name is atomoxetine, and it works a little bit differently. Instead of working on dopamine, it works on norepinephrine, and it's usually our second line medication for ADHD. It doesn't always work as well, but for kids who have anxiety and ADHD together, or for kids who can't take stimulants, it might be a good second choice. It might be something you might want to try even before. And again, those are things to talk about with your provider. So in ADHD in general, there have been 2 studies done, and it is FDA approved for use in ADHD. It helps symptoms. You can have some cardiac side effects as well with heart rate and blood pressure, and you can also have a little bit of poor appetite or nausea, but it certainly doesn't seem to have as much appetite suppression or, you know, kind of sleep difficulties that the stimulants have. But we should still be monitoring kind of, you know, heart rate, blood pressure, and growth. So this is also a medication that is appropriate to use. And then there's also medications that are blood pressure medications. So clonidine and guanfacine, they have long-acting forms called Capvain and Tuniv. And even though they're really used for blood pressure, they're also FDA approved for use in children who have ADHD. So there are studies that support this. Obviously, some of the side effects, because they're blood pressure medications, is they can lower your blood pressure. They can also cause drowsiness. So for some kids with ADHD who have problems with sleep, this is often a good first choice also, because, you know, sometimes the stimulants might interfere with sleep a little bit. So that's ADHD. Anxiety and depression. Again, I won't go in deep detail about this because I think Dr. Bolden did a good job. Cognitive behavioral therapy can be good. And I did see Christine's question about, you know, is this good for kids with 22q? And the question is, it depends, right? So for maybe your younger kids or kids with less who are less introspective are able to kind of talk about or, reflect on their behaviors and thoughts as well, maybe more of a behavioral approach or a modified type of CBT might be better. But for your older kids or those that can kind of engage that way, it's very effective. It's kind of our best treatment that we have. I think, to answer someone else's question too, that kind of dovetails with finding a professional who knows 22q. I agree, that's going to be hard to do. If you have someone, that's great, but sometimes what you want is someone who does CBT or someone who, provides other treatments or evaluations, etc., that at least have kind of a developmental mindset to it. So, I'm a developmental behavioral pediatrician. There are child psychologists. There are people who are trained to think about things not from maybe the adult perspective, but understanding children and developmental delay as well. So a lot of autism centers have people that can kind of see things from that perspective of individual differences and how to interpret some of the behaviors that we see or things like that from a developmental lens. Mindfulness and relaxation techniques can be very helpful too, and sometimes those are integrated with the CBT. These are some examples from Children's Hospital Colorado, and there are even some online CBT types of treatments for children. Child Anxiety Tales is one, and so that's something that you can look at for some guidance or can even be done with a therapist. These will be available for you later too, but these are also books that are helpful for guiding how to manage behaviors. And the main treatments in terms of medication, at least, are SSRIs, selective serotonin reuptake inhibitors. You might know them more as Zoloft, Prozac, et cetera. And these are FDA approved for OCD and depression in children. And there's a very good evidence base for them for anxiety. So those are good medications with good evidence. There can be some side effects, especially in little kids. They can get activated or kind of hyper on it. So you want to watch your, go slowly up in the dose there to keep that down. You can have headaches. There is a black box warning where you can have an increase in suicidal thinking in young adults and children, especially that are treating for depression. However, the data has shown that even though the suicidal thinking can be increased, there's not been necessarily an increase in suicidal attempts. But this obviously is something you want to monitor closely as you're starting therapy. And you also want to keep monitoring labs, et cetera. So we don't have any clinical trials for SSRIs and 22q, but there are kind of lower evidence studies such as case series showing that, in 3 cases, individuals, teens who had anxiety and hallucinations, those responded well with treatment with SSRIs. And then also at one of our prior international 22q meetings, Sanner presented a case report of 10 children who were treated with different agents for their anxiety. And not only did the anxiety get better, but their adaptive functioning, their real world skills, and then their executive functioning. So their organization and kind of ability to kind of plan also improved. And, I think that's hard too, that overlap between anxiety and ADHD. If you're perseverating and you're anxious, you're of course going to be distracted, right? It's hard to know what comes first. Sometimes, because you're disorganized, that can cause anxiety, et cetera. But I do, want to put that on the table as you're working with professionals on trying to figure out what target to go after first. Sometimes it's hard to know, is it the anxiety or the ADHD? Because they often have both. And then in terms of psychosis treatment, obviously a multimodal approach is definitely your best bet, as Dr. Bolden had shown in her nice slide. And again, atypical antipsychotic medications for psychosis are sometimes appropriate. There's some examples of the different generic names. And those medications are FDA approved for children over the age of 13. Some of these are even approved for children younger than 13, like risperidone, if there is an indication such as bipolar disorder or irritability associated with autism. So again, it's really important to know what your indication is or what target you're treating. Just because you're on an antipsychotic medication doesn't always mean they're treating psychosis. And the 22q International Foundation wanted to make a statement recently about psychiatric conditions in individuals with 22q are definitely treatable. They do not require different management than what you do for your general population. That being said, there are no trials in 22q for these antipsychotic medications. There's one ongoing right now, again in Geneva, looking at risperidone in non-psychotic individuals to see if it prevents them from developing other conditions. Their outcome measure is not psychosis, actually. I looked, it looks like their outcome measure is looking at ADHD symptoms to see if, this can kind of help improve functioning. But the take-home point is that these medications are effective and they're FDA approved for the indication. There was a question about tyrosine, dempster. So this is FDA approved, but not for psychosis. It is approved for pheochromocytoma, which is an adrenal tumor. And that because of that tumor, you make a lot of catecholamines, which are your stress hormones, and your blood pressure gets high. So that's what the indication, the FDA indication is for this type of medication. There was a clinical trial in 2010. They were hoping to get 10 people in, but it was the study was terminated early after 2 participants were in there. One was in placebo, one was in active drug. So we don't know if this works or not, or how it's going to go with it. So right at this time, there's no evidence to support the use of tyrosine in individuals with 22q and psychosis. I am not going to talk about complementary alternative medicines, but I am including some resources here in case you guys want to look at those. These are kind of reputable sources to kind of look at the science of what we know. Is there emerging evidence? Is there no evidence? Is there lots of evidence for certain conditions? You can look that up on here. And so my conclusions are to seek care early. Behavioral therapies are helpful and they can be combined with medications if symptoms are impairing. We know the two work really well together. There are no specific 22q medications currently. And we know that our individuals with 22q respond to standard and usual treatments and consider those coexisting medical conditions. Take them off the table because sometimes those are things that are easily treatable. And then talk with your doctor about the evidence to support the use of specific medications and what risks and benefits are, because it's not going to be like an all or none. It's going to be, what's your risk tolerance? Are we willing to try this for this, etc. So with that, I want to thank everyone. I want to thank Lindsay and the 22q Family Foundation and all of our funding sources as well. And I will stop sharing.
Thank you so much, Dr. Inglesary. So I think I love that you touched on just kind of overlining the different medications. We always get a lot of questions. Obviously, we're a foundation run by families, so we don't have medical professionals on our board, but we do get a lot of questions in regards to 22q specific, a lot of things. I think it's always a worry on parents' shoulders, and just important that you were able to highlight that, there isn't enough studies out there, but when you do go low and slow, a lot of these medications are effective, and there's also a lot of other therapies and resources out there for families. So everyone did answer quite a few questions along the way, but we do have some more. I was gonna relay some of those questions, and then of course, if any of the panelists have a question that you think I forgot to mention, please jump in. One parent asked, and this might be more directed to Joy, but anyone's welcome to answer, that she felt her son's depression came after receiving a 22q diagnosis, that he just feels like there's no point in medication, there's no point in a normal life. What are your thoughts on how to approach, like when you told Marin about her diagnosis?
Well, for us, Marin has known that she has 22q as long as she was old enough. I mean, it's since she was old enough to know, she's known about 22q. And so it's just always been a part of her. We're fortunate that we've been able to meet a lot of other families who have children with 22q, and we've developed quite a network. So it's, normal for her. So as far as the hopelessness of the situation, we've been there. Marin has been that way. And I think it took a lot of therapy, a lot of trials of medication, and a lot of working through it for her to get to a point where she realized that she could feel better, and she had to do the hard work to get there.
Thank you. And I also wanted to share, just on behalf of the foundation, that we have a program called Career Pathways to help with kind of bridging that gap between the young adults transitioning to adulthood, whether they're going to a college or they want to get a career and, be successful at it. So if you can go to our website at 22qfamilyfoundation.org, it's a free service that anyone can apply for both parents in our community, but also young adults and adults that really want to get out there and need that support to kind of take it to the next step. That, we want all of the members of our community to be as independent and successful and, happy and healthy as possible. So that's also another resource that we can provide.
Lindsay, can I also make a comment about that last question? I mean, I think it's hard and it's difficult. And of course, it's an adjustment coming, learning about the diagnosis. And when it is something that you are able to kind of do earlier and it's not a big shock or a big change in mindset, because it's not a, change of who someone is inherently, right? It's just extra things we may do to support. But some of that hopelessness is, as Dr. Bolden had kind of reviewed, is part of the depression. Right. And so hopefully that usually gets better with treatment. And sometimes at this point, like when I hear about something that in a very similar vein, again, I'm thinking of a patient I have who's not someone on with 22q, but at that point, we really stepped up intensive outpatient services. So more on the behavioral side of not just, a therapist once every other week or something, but really engaging more frequently. And, that may be helpful at this point, because maybe what you're seeing here, of course, maybe was triggered by a big event, but it's really what we're seeing is the signs of depression. And at that point, maybe increasing kind of the behavioral side of things could be very helpful.
Yeah, I think it's hard too. Like when Joy said, my friend as well, like they've always known. I think a lot of times though in our community,
have that option.
late diagnosis. Yeah, you don't have that option. So that was an important question. Thank you guys for chiming in on that. Okay, I have another question just in regards to resources out there for adult children 21 and over. I mean, I think we kind of touched on this, but to deal with anxiety, ADHD, and navigating the adult world. I think if this person is asking right, or if I'm understanding right, sometimes there is that transition from like your pediatric team to the adult team. And that's something also that we get a lot of questions about is where do I take my adult child,
Right.
adult too. Where do I take them, or how does that work? When they had this previous team and now they're not considered age appropriate for that team.
And I think, every state by state, it also varies in terms of what kind of support you can receive for adult services for your individual. But I would, for those of you that are hooked up with those services or could, investigate whether or not you could plug into that system with whether it's vocational training or, other supports in the community, those are big on the adult side. In terms of 22q specific adult services, I think Toronto's a big center that, may also have like more resources to help guide as opposed to provide direct service. But
for ADHD specifically, which I think the question was about, the strategies are quite similar. They're not particularly different for adulthood versus childhood. You just transfer the setting of them. So the way in which one needs to be organized and the different behavioral strategies are pretty much going to be the same. Being able to have frequent breaks when you need them, knowing when you need breaks, having what we call distractor stimulation around you that can blend into the background as white noise so that you can continue working when you need to is going to be very similar. So just the environmental and behavioral changes aren't going to be different strategies so much as just different contexts in which you use those strategies.
Great, thank you so much. We have another, I would say it's not super specific, so I'm gonna throw it out there. Someone asked that their 8-year-old daughter has 22q and ADHD. She recently started on, and I'm sorry if I butchered the names of these medications, Concerta and fluoxetine. Thank you. Like I said, I was going to butcher it.
Concerta and fluoxetine. Yeah.
Yes.
Okay.
For concentration and frequent emotional outbursts and anxiety, would you recommend switching to one medication approach like Strattera?
So I probably can't answer that question without kind of knowing the individual situation. If it's working well for her, then I stick with what works. But if you're looking for something else anyway, then that's probably something to at least talk to your doctor about. I mean, I think if the anxiety is very significant, the Strattera isn't going to probably be enough to get at it, but you could try, to try to get the ADHD and anxiety with one agent. It's worth asking about at least. But yeah, if things are working, I would probably go with what works.
I have a question. What is your take on how to get school personnel kind of more on board when it comes to anxiety? And this is personal experience, but I think it's for a lot of families. So when you haven't maybe formally been diagnosed, maybe it just needs the formal diagnosis. You come into school and on the chart, it says 22q or George or however they call it. all the health impairments. And then you start talking about anxiety, and I think because of today's world, like there's a lot more out there about anxiety, and more people are realizing, wow, I really do have anxiety. Not to say it's normalizing it, but to me, what I'm getting a lot from the school team is that, well, it's just anxiety, that this isn't something major. And so I think that's a big frustration because of the outbursts and the way that it's being through my son and his kind of personality. It's taken more as like defiance and behavioral than an actual medical thing that's happening with him, and he needs support. I guess my question is it more so that, you know, families just need to get like a formal diagnosis provided by, you know, a doctor to be added to their chart? Is that like kind of what you recommend?
Yeah, I think, go ahead, Kalima.
When it comes to dealing with the school, so, you know, I've sat in on IEP meetings. They're frustrating, even for me, and I do this for a living. So definitely having a formal diagnosis can be helpful, and also then having an advocate in the room. We at our clinic have a supported education specialist who goes to those IEP meetings because they know what to advocate for. This is what the issues are. Here are the different accommodations they need. This is what you need to give this kiddo. So even if you don't have a supported ed advocate, if you have a psychologist who did the evaluation and says, here's the anxiety issue, here's this issue, particularly child psychologists know how to write recommendation letters regarding what accommodations they'll need, so that parents can actually ask for them and advocate for them. Because even just giving the label and saying, here's the diagnosis and the symptoms, that still leaves it up to the school to say, oh, here's the accommodations I'm willing to give, versus when you write a letter that says, here's what the problem is, here are the exact things this kiddo needs, will get you a little bit more buy-in, but you'll still have to advocate and kind of fight for them too.
Yeah, definitely.
Yeah, I wish that weren't the case, but it is.
And Lindsay, I would say, I think you brought up a good point about, they're seeing it as oppositional behavior, or, you know, catching it under a different kind of theoretical kind of symptom category. So sometimes it can also be helpful to ask for something called a behavior support plan, which usually means you ask for something called a functional behavioral analysis first. So their school psychologist comes in and sees the behavior. It's not just, you know, the teacher's interpretation of it when they have to have their attention with 23 other kids, et cetera. It's like, okay, well, one outside, you know, one of their people is there and saying, this is the behavior, this is what happened right before it, this is the response to it that either reinforced it or didn't. And that is also helpful too, because it's one of their team whose job is to kind of think about what those interventions are. But if you already know, like, okay, well, he needs to know in advance when the bell's going to go off, or today's a fire drill, like those kind of specific things can go a really long way. And just asking for those in and of themselves, you know, could be written into the plan even without a diagnosis. But it takes a lot to convince them, I think, you know, for like they're such small things, and you're like, they're small, but if we don't do them, it's going to ruin the whole day. And I like understood.org in terms of a lot of kind of IEP recommendations or things to think about in terms of whether it's sensory breaks or, you know, things like that. You can get some good ideas too. But I would certainly say, I agree with Kalima, if you can get a psychologist who's doing this evaluation for you and spelling it out for them, hopefully they will take that advice, you know. I've had times when they don't take any of our advice, but
I know. Well, and that's what we do at the foundation, you know, is provide those advocates, and even then it's still sometimes a fight. So I think if anything, I learned from this conversation that, you know, we're advocates for life for our kids throughout all aspects of their life, you know, and so even when you're talking about medications and, you know, not just trusting the professionals, because you're with them 24/7, you know them best, and so, you know, be taking that data, whether it's in their educational journey and trying to advance them through their learning goals, but also like how's medication working and how it's affecting them. So we are way over time, but I don't want to value everyone's time here, but also, were there any questions that you three think I missed that we need to, a lot were covered, I think, as you were talking.
Yeah, so Kathy answered this question. I just wanted to expand on it a little bit, and then I'll be done. Whether or not CBT is helpful for individuals with 22q. So as she very rightly said, it really depends on the individual. If you're seeing cognitive impairment, so significant difficulty understanding multi-step instructions, thinking about their own thinking, that tends to be a slight contraindication for cognitive behavioral therapy, because a lot of CBT is taking your thoughts out. examining them and then reshaping them and moving forward. If that's going to be a struggle, that will be difficult, but that doesn't mean that behavioral treatments in general don't work. So oftentimes when I'm working with anyone, kiddo or adult, who has those difficulties in their cognition, you start with the behavioral stuff first. So doing a functional analysis, doing a behavioral, kind of like applied behavioral analysis that you would do for kiddos with ASD, you do something like that to show them, okay, you see, so we do this and you feel better. That means that this thing is good, it works, you know, so you kind of do the cognitive stuff on the back end. You do a lot of demonstration and behavioral proof, I guess is the best way to say that first. And then you can add some of the cognitive piece. So it's often a little bit of a combination of ABA and CBT for individuals who have those cognitive impairments. But for those who don't, if they are typically developing or they don't have significant cognitive impairments, CBT works just fine.
Thank you for clarifying. We did just have one question that I'm typing in the chat about where they can find the recording of this webinar, which all the recordings for all of our webinars are on our YouTube channel, so you can find us at 22Q Family. Any last questions or thoughts? I think this is a really interesting conversation. It's highlighted a lot of different areas of mental health and how you know, medication can help, behavioral treatment can help, and just being, you know, an advocate for your child, but eventually teaching them to be an advocate for themselves. So very appreciative for all three of your time. And then hopefully in the future we can do this again, because it's definitely a topic that is very important to our community. So just wanted to thank all of you for your time again, and I hope you enjoy the rest of your Sunday, and looking forward to getting together again soon, hopefully in person.
Yeah.
Well, thank you so much everyone for joining us, and have a great afternoon. Goodbye.
Bye.
Bye.